All right, welcome. We are recording. I always say live. Yes, why not? We're live because we're the two people in the studio. This will be broadcasted everywhere throughout the digital stratosphere. And I'm super excited. I have a friend of mine, Joe Ebberwein, and he is one of the co-founders of Corstrata, which sounds super cool. I think it sounds like something out of Star Trek or something, but I love it. And Joe, tell us a little bit about yourself, real quick, just the 30,000 foot view. I hate doing bios and intros. I really butcher them all the time.
Absolutely. Great to be with you today, Michael. I looked back and I think we first spoke about 7 years ago. So it's been a great journey and really appreciate your friendship and mentorship. But I am Joe Ebberwein, co-founder and CFO of Corstrata. My background is actually accounting and finance, but I've spent over 30 years in the post-acute space, if you will, home health, hospice, private care, and telehealth, early days of remote patient monitoring, and really formed Corstrata out of a significant pain point that my co-founder and I had experienced in the home health space. Never could find enough specialized wound nurses and really used them quite inefficiently. But we were one of the early adopters of remote patient monitoring back in the early 2000s when it was really clunky, expensive equipment that you plugged into a phone line, really. And that taught us a number of lessons. And we have taken those lessons and applied them through Core Strata to the wound and ostomy problem.
Yeah, no, that's super cool because I feel like we still have not seen RPM or RTM or I don't know. There's so many of these codes and different things. The whole thing is trying to deliver care the way it needs to be seamlessly. And so
Yeah.
that's fascinating. You were like starting it like it's like pre-internet, like when it was in the government. It's 2000. It just that's super cool. So you're expert on that, but let's get at hand like the big problem. Most people, I'm sure, have no idea what the heck wound care is, how big of a problem. What did you say? 100 billion cost to the healthcare system. Even though, sadly enough, it seems like cost doesn't matter. It's like just layered on, but you are solving a serious problem. Tell us a little bit about that. Help us better understand that.
Sure. So, we do call it a silent epidemic because it is not forefront with some of the other chronic conditions like congestive heart failure or COPD or chronic kidney disease and stage renal disease. But it crosses multiple disease states. So, about 16.5% of all Medicare aged population have a chronic wound. And what are we really talking about with chronic wounds? We're talking about the result of underlying conditions usually. So we're talking about diabetes related foot ulcers, vascular wounds, lower extremity, pressure injuries or pressure ulcers, or you may see on your TV that a lot of attorneys focus on bed sores in institutions, and those are serious chronic wounds that many of which are preventable. Wounds associated with chronic kidney disease and stage renal, upwards of 30% of that population have a wound. And ultimately, wounds that appear at end of life as the person's condition changes and can't support skin integrity. So these are the type of wounds we're talking about, and why it's somewhat silent in an epidemic. From an epidemic standpoint, is there's not a medical specialty for wounds. You go to a cardiologist, you go to a nephrologist, or any of a number of other specialists. You don't go to a woundologist. You may end up at an outpatient wound center as a result of somebody identifying a chronic wound, but only a small population or a small percentage in the population of persons with chronic wounds actually ever make it to a wound center. So it is a silent epidemic. As you stated, it's over $100 billion problem, and it's only growing with the incidence of diabetes and other chronic conditions.
Yeah, so when does it happen? I mean, I imagine there with neuropathy and these conditions, the individuals that are beginning to get this onset are not the best individuals to say, "Oh, I have this," right? Their cognitive decline. So that's probably part of the problem, not being able to detect it.
Exactly, and you hit the nail on the head from the standpoint of diabetic foot ulcers. Often they're not even diagnosed until someone presents at the ER with a gaping hole in their foot. Not to be overly graphic, but they can't feel it because they're insensate. So these are not just Medicare age population. These are often persons with diabetes, many of which are not diagnosed yet, and they end up getting a diabetic foot ulcer because they've lost sensation in their feet. So these are working people. I mean,
Mm,
these are people that are trying to keep jobs, and this is often very limiting when you start getting diabetic foot ulcers. Just to put it in perspective, Michael, 1 in 4 diabetics will acquire a diabetic foot ulcer. One
mm.
in four of those individuals will have an amputation. And the 5 year mortality post amputation is upwards of 70%. So this
Yeah.
is a
Mm.
significant issue. And not just Medicare age, but as you said, as people become more polychronic and don't have the ability to really be as mobile, a lot of pressure injuries result from that, from just being bedbound or chair bound. And so we see that across multiple care settings.
Yeah, I'm so glad we connected. It's been a while, or reconnected. I'm glad you said 7 years. I don't know. I think you put that, you shared that out there, blasted it out there. And the sad reality is, you and I have unfortunately never met in person and at the right conference at the right time. You know, it's like,
Right.
or wherever it be. But this is, I mean, we're basically part of the Corstrata infrastructure, right? We're connecting digitally, remotely via LinkedIn, and it's the same thing that you're doing. This is the new way. Tell me, I know you were sharing a little bit about your founder journey. Obviously, you've got a lot of experience in accounting, the bookkeeper, but was it hospice, your experience in hospice, where this sort of initial where the need came from?
Yeah, it was really kind of a joint experience between working in a home health and hospice provider. So we had both home health and hospice services, and really from a finance standpoint, really getting into the nitty gritty of care delivery and seeing the pain points, seeing that our nurses, often did not feel comfortable working with wound patients, and if we didn't have access at the time to a certified wound ostomy continence nurse, then we were in some ways kind of flying blind, if you will. And we were doing more visits than we needed to. We weren't using the right advanced dressings. And really, the market is really interesting. As I said, there's not a medical specialty from a physician standpoint, but certified wound nurses, there are only about 10,000 of them in the US, and only 10% of those practice in the post acute space.
Mhm,
So you've got like a 1 to 1,000 patient ratio. So it's not sustainable. And so the virtual model, just like you said, we're talking virtually. We've developed a friendship and a relationship virtually. There is an opportunity to provide virtual wound care, and
mhm,
we've tested that thesis over the last number of years, and we know that it works. In many cases, it's better care because the nurse has kind of an undivided focus on the patient and our customer's caregiver that's in the home, whether that be an LPN or an RN, or in some models a paramedic, who is kind of the hands-on care. Our nurses are able to really focus on that care and not be distracted by, being called to
mhm,
multiple floors in a hospital, etc. So that's really how the model
mhm.
evolved. But it was through the use of telehealth in the home health space where we saw there's got to be a way to use technology
Mhm.
to solve this
And
problem.
so are you agnostic? Can you just do it with a phone now? Do you do devices to get a better signature reading with depth? Where are you with how you actually the early onset of once you like maybe walk us through the where a patient comes in and or the RN's using your solution to build a process. That would be helpful maybe.
Sure. So let's just talk about home health, but we could be talking about SNF or hospice or hospital at home, any of those models. The we engage with a provider. Currently, our customer is a provider. And so their boots on the ground, if you will, are going into the home or are in a skilled nursing facility, etc. We have a very easy workflow with them. We can, and we are, as you said, agnostic to the technology. They may already be using one of the really leading edge wound imaging software applications, and there are a number on the market. We have great relationships with Swift Medical, for instance, and those allow for photograph of the wound, analysis of the wound, and are really leading edge auto measurement, a number of different functions. And then you can see that longitudinal view of the wound, and our nurses are able to do all of that remotely. But if an agency or a facility has not adopted a wound imaging app, we have a very easy workflow by which they, on their device, they can take a photo of the wound, document basically some of the characteristics of the wound. That's transmitted to our nurses who do a thorough assessment and make evidence based recommendations back to the customer. Now, where that becomes important is we see about a 30% error rate in identification of the wound type. And that is an issue because number one, coding and reimbursement, but also what evidence based treatment plan needs to be implemented for that particular wound. So, just as an example, if it is an arterial based wound versus a venous wound, you're going to use a totally different treatment plan. You're not going to use compression on an arterial wound. And I know I'm kind of getting in the weeds, but it's so critical, not only
Mhm.
from an outcome standpoint, but also from a legal liability,
Mhm.
from patient satisfaction, outcomes, all of that. So, again, we're agnostic to the device. A lot of our customers bring their own device,
Mhm.
and we can seamlessly interact with them. We also offer live HIPAA compliant video, and that's extremely important. For instance, if the person has multiple wounds, our nurse can see visually the patient and where the wounds are in proximity to the other ones, what may be the underlying condition. Perhaps they're not on the right bed surface, from a DME standpoint, and that's causing pressure injuries. Um, Also, live video is extremely important with our ostomy population because we can see the person with an ostomy actually take down their appliance, put on their appliance, check for issues that may be leakage, etc. So,
Mhm.
two modalities: store and forward image review and live HIPAA compliant video.
And Joe, with what you do, um, your business model. So I guess it's a few different. I mean, is it like a staffing model? Like what? Like, and I know you were sharing. I mean, obviously, the bigger vision is what we were talking about offline, and I won't get too much into it. But you shared with me you had gotten some really serious milestones with some really significant providers, payers. That value based. I know that's where you're going. But
Mhm.
meanwhile, sort of what is your business model? Are you staffing? Is it tell me like how that works?
Yeah, right now it is a consultative model, and we provide access to board certified wound and ostomy nurses for providers who do not have access. So that is more of a consultative model. We can we can do kind of a per consult model, Or if that person is more episodic, like in home health where they do 30-day episodes, we can be involved in the initial evaluation of the patient on admission and then follow that patient kind of longitudinally through the model.
Mhm.
That's a couple of different models. Some of them, for instance, currently in the hospital at home space, they're more of a one and done kind of consult. As hospital at home evolves, we see opportunity for more longer term care. But as you said, as we move into more value based contracts, like with ACOs or Medicare Advantage or certain payviders who are both provider and payer, we see a different model that is more value based. So we're not just fee for service, kind of per visit or per consult, but really working in eventually even at risk models.
Okay. And is it, where's been your biggest, like, I know you've been in this for a while. What has been your biggest challenge scaling and growing?
Well, capital is always or can be a challenge, especially over the last few years with the market the way it is.
Hmm.
We do have some kind of exciting funding opportunities on the horizon, that will really allow us to scale this operation even more. Sometimes the challenges are still that incentives are not aligned. So, for
Hmm.
instance, if the home health, I'll just use this as an example. If the home health company has nurses that are doing their own scheduling and kind of managing their own patients, a lot of times when our nurses perhaps recommend reducing the number of in-home visits, which is a cost savings for the home health agency, if those incentives are not aligned with the nurse out in the field, whose compensation is dependent on visits, that can be a bit of friction. So, in an ideal world, we are very much integrated into a very efficient use of resources. Now, interestingly, right now, home health and multiple providers, as you well know, are having issues with staffing. There's about a 26% referral rejection rate in
Mm.
home health. Well, actually, it's even higher. It's upwards of 76%. And that is because they don't have the staff to adequately care for these patients. So they're rejecting referrals. That's where we can come in. We can help an agency not only accept referrals, but then have better outcomes, if that
That
makes
is
sense.
just, that's just, when I hear that, like churning away business because you don't have people, that's just
Right.
so awful. So, but are you also, so you've had a lot of experience with telehealth, remote patient monitoring. Are you trying to do a lot? Do you have some sort of bridge where you're also able to help align that payment with those home cares on the back end? It seems like you've had to be really agile as to get,
Mhm.
make it work for, I mean, obviously there, I mean, I hate to say it, home care, wouldn't we still say like 70% of them are fee for service? So, I mean, do you try to align with that, and how do you do that?
Yeah. So currently, about 50% of the business or the patients that are coming into certified home health, about 50% are traditional Medicare fee for service. And interestingly, that's an episodic rate. So Medicare pays a 30-day rate to those agencies to care for wound patients or any of the patients. The other 50%, which is growing um, pretty rapidly, is Medicare Advantage or managed care. And that is traditionally a per visit rate, oftentimes much lower, sometimes lower than even the cost of the visit for the
Mm.
agency. So that is a really tough place for certified agencies to be in right now. So what we're helping them do is look at ways that they can accept wound care patients and be able to justify higher rates with the Medicare Advantage because of all the resources it takes. So these Medicare Advantage plans, they're in a conundrum because their revenue is at stake, their star ratings, all of that. So not all of those incentives are aligned. And
Mhm.
in some ways, like you said, we can be that bridge. We can help them with their wound population. We can help them with their data, with their outcomes data that shows that they're keeping the patient from a readmission or from an ER visit or from a wound infection that ends up, being a readmission to the hospital. All of that data helps justify to the Medicare Advantage plan why they are kind of a center of excellence.
Okay,
Hope that
so
makes sense.
yeah, well, that was a mouthful. I was kind of got lost a little bit, but I guess what I'm hearing is there a way that you must work with some of these Medicare Advantage home care companies that might maybe are they using lower level staff, like maybe not a PT or maybe a different level, but they're augmenting it with your technology on the back end. I mean, how do you make it work so I mean, just like maybe one user case or scenario. I'd love to hear
Sure.
that because it seems like it's always about either lowers the skilling, getting that FTE right in order to make it right.
Yeah, it's again kind of a loaded question, and I'll try to keep it to a use case. But um, we're we're early days in getting into the payer space. We have done some work with ACOs, but some of the Medicare Advantage plans now that we're in discussions with have boots on the ground. So they're sending primary care physicians, into the
Mm.
home or nurse practitioners. And those people are not certified in wound care, yet about a third of the patients have a wound. So we're able to work with them to really virtually provide that oversight of that wound care and ultimately work directly with the patient. So it reduces their need for in home visits, managing the patient better, making sure they have the right advanced wound dressings, and lowering the overall cost of care for those patients. Um,
So when the patient using their phone to give you guys details on it, or is it always, or is it a hybrid, or is it always the a provider, or someone boots on the ground that's doing the footage or whatever, doing the video consult?
It's it's both.
Hmm.
For wounds, it has traditionally been the provider at the bedside, whether that be an RN, LPN. In the hospital at home models, we're working with paramedics. So
Hmm.
it's interesting the different levels of specialization that we can work with. We are moving toward the patient or caregiver being able to send us wound images, especially in those pay vider models. But for the ostomy side, it is 100% the patient brings their own device, and we do a HIPAA compliant video visit
Cool.
with the patient caregiver in their home.
So it sounds like because of the ostomy that you just described and all your experiences, I know it must make it really complicated, but it also makes you guys nimble and flexible and trying to get the right point of solution. So, um, I would you say? I mean, it's like everyone talks about value-based care, but you would not be in business if there was just value-based care, but the end goal is to get there, right? So tell me about your evolution as a business with, fee for service, what you're doing, and then the value-based care, which is ideally, you're solving a problem, you can go full risk. That's where we're all hoping that healthcare will
Nirvana.
be. Yeah, nirvana. Not to be confused with Kurt Cobain, right?
Right. Yeah, I mean, so as we have evolved, we have been in this model working with various providers who have multiple reimbursement models. Like for instance, hospice. They have a daily rate, right? So we work with hospices who are dealing with managing that daily rate and those outcomes related to that. Home health it's 30-day episodes. Hospital at home, it's a short length of stay. And so we've adapted, like you said, we've been kind of agile in the way that we work with each one of those models. But ultimately, if you look at the just the Medicare certified home health episode, we have case studies that show that agencies who were accepting wound patients were doing every other day wound care visits, sending a nurse into the home every other day. So 15 visits per 30-day episode. With us, and with coming up with an evidence-based treatment plan using advanced dressings that allow for longer dressing wear time, we cut that in half.
Hmm.
So you can kind of see that overall cost per patient coming down in nursing staff productivity as well as reduction in wound supply cost. So all that data that we've been collecting, all of our outcomes data, and we've done over 40,000 individual wound patients now. We're
Mm.
taking all that data, we're compiling the outcomes. We have data around what supplies were used and which ones are the most efficacious. What is, and kind of our secret sauce, if you will, Michael, is that we've developed algorithms for, or kind of care pathways by wound type, by care setting. So all of that data is really driving that evidence-based care, which ultimately a payer, they're very interested in it.
Hmm.
If you can
Hmm.
even get them first to understand
Yeah.
what their wound cost is, then when we can start talking about we're reducing that episodic cost by half,
Hmm.
they kind of sit up and listen.
Well, it sounds like that's where you should go. I mean, is
Yeah,
that the water? I mean, all the other stuff just seems too complicated, no alignment. Like you said earlier, the incentives that aren't aligned. You are aligned with the payers, right? I mean,
yes.
they want to be with you. They want to be going there. So tell us about that.
That's definitely where we're going, and that's where, obviously they manage those resources, and ultimately it's getting them really to see that number one, they have a wound care problem. I mean, reality is some of these payers, and you would be surprised at just the magnitude of the ones I'm talking about, literally ask us for what are the wound codes, what are the ICD-10 codes that we should be looking at, because it is a silent epidemic. It's
Hmm.
hidden. A hospital admission for sepsis may have a diabetic foot ulcer as the primary cause, but you're not going to see that in your data, right?
Hmm.
So ultimately, it's getting in and integrating with the data and then really looking at who is at the highest risk for development of a wound. And that's on our roadmap as well, taking our data and really working from the prediction
Mm.
standpoint. Which of those 1 in 4 diabetics that's going to get a diabetic foot ulcer, which ones are at highest risk, and what can we do to get ahead of that? There's a lot of
Yeah.
prevention that can be done.
I like that. That's something that's one of my missions is the metabolic health. We need to reimagine not to sick care, but avoid it. I mean, so
Right.
if you're able to say it, then you could realign the risk, the cost, and work out a pretty darn a good agreement because they don't want to pay 50 or 45, whatever it is to do an amputation. I mean, that's just not hospital. I mean, the payers love you if you're able to assign those predictive models and you get them, love them, help them, keep them off of any of even your, I guess that's Corstrata 2.0, right, where it's like you get them before they have a wound. I mean, right.
Right. Yeah. I mean, this is a really interesting fact, but the HEDIS scores that the plans are measured by, and that physicians are measured by, um, di- screening for diabetic retinopathy, which is a common condition related to diabetes. That is part of the HEDIS score measure. But the same the same clinical pathways that cause diabetic retinopathy also cause peripheral neuropathy. And
Hmm.
yet, that is not a HEDIS score. So, the diabetic screening of the feet for potential risk of ulceration, it's not on the radar. So, a lot, I mean, we always tell our patients, our nurses tell our patients, if you are diabetic, you need to make at your annual exam, you need to make sure your physician is examining your feet. It's
Hmm.
just a no-brainer. But the measures aren't there to to adjust for the
So
payment
are you
model
now
for that.
telling me, Joe, that you're a lobbyist now too? You're a policy guy?
With a lot of things. Like for instance, why when ostomy clinics are closing down across the nation, and you've got young mothers loading children in a car and driving 4 hours to the nearest ostomy clinic, why are specialized ostomy nurses not able to bill? They're not,
Mm-hmm.
because they're nurses. They're not advanced practice. And yet they should be, because they're the only resource. You
They
don't go
need to
back to a,
they need to work for you, Joe. Those are your new people under Corstrata. You get it right.
oh, yeah. I mean,
Are you
we
doing some
have,
recruitment? It seems like you're the umbrella to make all things wound care and ostomy happen.
well, an interesting byproduct of COVID was that all of a sudden there were a lot of nurses who were either leaving the field, retiring early. I mean, you read the stats, we have a waiting list now of a significant number of certified wound and ostomy nurses who are ready to go as we scale, because they are tired of the physicality of the hospital, or
Hmm.
all of the things,
Yeah.
that go with that.
Are
So,
are you certified, able to give them the certifications? Do you have any training modules to get those CEUs under Corstrata? Are you partnering with anyone as you build up your workforce for that?
yeah, so right now we work with nurses who are already certified, and
Okay.
again, we have a number of them kind of coming to us wanting to work with us. But what we do offer is continuing education and courses for our customers' nurses who really just need to understand basic wound care, basic etiology, and so we do a lot of education. We're
Mhm.
working. We have some exciting announcements coming probably as early as June on some CE that we're working on with some national organizations, physician
Cool.
groups, and that kind of thing. So yeah,
Well, Joe,
education is a major component.
We got about 10 more minutes. I want to
Okay.
make sure I have you shine. I want to make sure we test it. We make sure that we're fair and unbiased, maybe a little biased too. I don't know. Whatever. Who knows? We're human to human. I want to make sure we're doing the right thing. So what do we need to talk about as we have, let's say 7, 10 minutes left, or if you get tired of me, you say, I'm done. I want to make sure I don't miss it. So anyway.
Yeah. No, I just think that a lot of it is awareness. It's interesting because, and I think you and I have had this conversation, it, it's almost inevitable that whoever you talk to has either had a personal experience with a loved one who has developed a wound, and people don't know where to go. They go to their primary care physician. They may get referred to an outpatient wound center. We're hearing as much as 8 weeks
Mm,
in being able to get an appointment at an outpatient wound center. A lot can happen with a wound in 8 weeks. If it goes south, it can, be sepsis, etc. So it's an awareness that there are and need to be alternatives to the
mhm.
current very fragmented, broken delivery system. Right now, a lot of wound patients, especially ones who are kind of dealing with multiple wounds that are pretty serious, they become really a hot potato in the
Mhm.
system. We recently saw one case where an LTAC was discharging a patient bedbound patient with multiple wounds to a home health agency with orders for twice a day wound care. That's not feasible for a home health agency. They don't have resources to send someone to change dressings twice a day. Imagine the imagine the quality of life for the patient to
Hmm.
have those dressings changed twice
Hmm.
a day.
Hmm.
It's not
Yeah.
feasible for a caregiver. So
Yeah.
it's anecdotal, but it's kind of points to the problems in the system. So our nurse got involved, came up with a treatment plan that allowed for the caregiver to change the dressings three
Mm.
times a week
Yeah.
versus twice a day. Those are the kind of things that, with access to the experts, can really profoundly change the outcomes clinically
Yeah.
and financially and quality of life. I mean,
Yeah.
it's a
It, it- it's
quality of
it's
life
it's
issue.
sad, but it's like a no-brainer, and it's just we have to keep on having companies like you that are, really more common sense because you saw a problem that just wasn't being solved. Not
Right.
saying your technology and all that other, there's some hard stuff behind the scenes, but most of it's just human to human. And so, I mean, I
Definitely.
know I shared with you with my father. He's 91. He's on hospice. He has dementia, and everyone's like, "Oh, I'm so sorry." No, he's like, look at the percentage of people that live to be 91. I don't care where it is. It's a 1% of a 1%. 1%. I mean, it's so. He's lived a really great life, and I will
Right.
say, and I don't say it all the time on my show, but I try to, is awareness, just like you were talking about.
Mhm.
Hospice has been such a great experience. And the sad reality, I think it's just on par like your wound care, is there's too much conflict of interest in our incentive driven model to begin to have that conversation. They don't
Mhm.
want, they really rarely, it wasn't until this, like my dad was hospitalized 2 times within 12 days.
Mhm.
I guess they got their 3 day stay, but we finally were able to have my mom talk to the nurse practitioner, palliative care, who was able to empower my mom to lessen that guilt, what I call caregiver guilt bias. She
Right.
does not want to be the person that looks to all the other children, the siblings that she gave up, or that it was her decision. So there's so many medical decisions that need to be happening that just aren't. So when I hear
Right.
AI and all this stuff, it's like, no, we need to have smarter conversations embedded
Mhm.
and designed in the care. But there's a lot
Right.
of misalignment. It's all about incentive. It's all about finance, unfortunately, sadly enough. And
Mhm.
so what that means is you are part of this. I am part of this. Everyone's part of this. And payers can be really good part of this if we can all,
Mhm.
like they're not always evil. I mean,
No.
and so part of this discussion is just trying to, and I hope that value-based care, we can start seeing more of this where it's more flexible. But anyway, I also wanted to say, and I'm this is not for me to be talking but so much, but also, my dad, there's a lot of care that needs to happen. So I
Mhm.
help periodically with his showers and this and that. We're
Mhm.
so thankful for home care. And yeah, it would be nice to know if there was something simple of an assessment, because he's at risk to pressure ulcers, not due to
Mhm.
diabetes, but just being bedbound like 16 hours a
Right.
day he's just sleeping a lot. So anyway.
Right. Yeah, and I mean that kind of education should be available to family members and caregivers, and just even simple techniques to reduce that pressure and those kind of things. So you're right on. Hospice is a huge passion for me. I've been not only involved in the provider space, but also on the board of the Hospice and Palliative Nurses Association for over 6 years, and now on the credentialing board. And you're right, hospice is like this gem that
Hmm.
enough people don't know about, and the whole perception of palliative care and hospice is changing. I mean, just even having former President Jimmy Carter on
Hmm.
hospice for
Hmm.
over a year now,
Yeah.
right? It's breaking down a lot of misperceptions. Now, I will say that it was kind of sad to me that Rosalind Carter only got on hospice the last 3 or 4 days. Like that's more typical, right? You
Yeah.
have this rush to hospice at
Hmm.
the end of
Hmm.
life,
Hmm.
and yet someone like her husband's had the benefit of it for over a year. So there's a lot of still work to be done, but it's really the ultimate value-based model. Uh,
Yeah.
it is it is truly a capitated rate, and you've got
Yeah.
this multidisciplinary team of physician,
Yeah.
nurse,
Chaplain
dietitian,
comes out, the
chaplain.
medications are taken care of, all
The
this. I mean,
social
200,
worker is
yeah.
critical. I mean, yeah, it is the. To
And
me,
then
it's the
they
ultimate.
have two, even though we have a caregiver for my dad through his policy, um, for a certain amount of time. I mean, that's
Right.
6 hours, 6 days, 36 hours. It's still a lot on my mom. So we need to
Oh,
provide help and support. But they do, I think maybe twice a week. I don't know, but just some aids, maybe helping
yeah,
periodically, bathing, washing. That's through hospice. But what
yeah.
I think is the most important thing, where it really solved the problem for my mom as a primary caregiver. What do you do at that 9 o'clock call when he's having respiratory issues? So
Right.
that was when he was last hospitalized. He was last hospitalized when I had to come over. I mean, I kid you not, it's almost 6 months for his research, something like that. But I had to come
Mhm.
there, and the paramedics were there. He did not want to go. He's like, I ain't, he didn't want to
No.
go to the hospital. And then he woke
Right.
up in the morning at 5 in the morning, ready to go. So I had to drive him. He got
Mm.
enough energy. And it was those few days that stay when we were able to get the right decision and get him on hospice. And so what
Right.
my short point, what I'm trying to say is the fact that now we have my mom 24/7 able to call that nurse when anything like that happens. She calls the nurse. That is the blessing of hospice, because there's just certain things that we're not able to do that my mom,
Mm.
as an 85-year-old, should not have to stress and worry. And that's a huge stress. So,
That's
um,
huge.
yeah,
Yeah.
that's the peace of mind, and not to go to hospital. And my dad does not want to go. There's nothing they can do. They can't operate. They're not going to do any heart. They're not going to do, I
Mm.
mean, IVs or whatever. I don't know what they would do at this point. So I just wish they really should have been having this conversation, like seriously. I don't want to say 2 years ago, because really it's only 6 months, the certs,
Yeah.
but maybe about a year and a half. I mean, it was just he wasn't a candidate for any invasive. He's got heart disease. He's got a
Right.
whatever his artery. I mean, it's dilated. It's constricting. So he's not
Mhm.
that's getting smaller and smaller. He wasn't a good candidate for a certain procedure, and he's got dementia. So anyway, I'm a little passionate about this, but I think it's
Oh,
important.
me too.
So anyway, I'll stop. So
Well, and when I was involved with hospice, and even today, there are plenty of people who come on hospice, and then they get stabilized. They can almost take a breath that they're not constantly having to go in for procedures, and just the frenetic aspects of that.
mhm,
But then they actually do improve, and they graduate from hospice, and then down the road they may come back on. So hospice is more fluid, I think, than
mhm.
a lot of people really understand. And
Yeah.
so, yeah, I'm passionate about it too. I could go on and on.
Well, Joe,
But
I'm glad you brought that up, because I did want
yeah,
to. I will say his quality of life ever since has improved
yeah,
astronomically. Like, how many he doesn't need to see a doctor anymore, like to go to an appointment. It's just ridiculous. So all those little things,
yeah,
like you're saying, it's like we're now taking care of them. It's dignity, respect, and honor at this point.
right.
So
It's so true. Yeah. And we're fortunate that from Corstrata's standpoint, we're working with hospices to equip them to better care for hospice related wounds, and prevent
mhm.
them. So
Yeah,
yeah,
yeah.
it's
Well,
good stuff.
this has been awesome having you on. I really so glad that you said yes, that we were able to connect.
Always, always great to talk to you, and it's an honor to be on your media as well.
Yeah, the planetary health first, Mars next. It's a mouthful. We might just shorten it for everyone, I'll tell you. Well, but
There's a lot
anyway,
to be done on this planet. So
yeah.
thank you for your part in doing it.
Yeah, absolutely. Until next time, friends, I hope you enjoy the journey on Planetary Health First, Mars Next. We had Joe share a lot about what we can do to improve wound care, and have a great